All right, now we should be streaming live. So we should be good to go, and everybody should be able to see my screen. And it's 11:30, so let's get started. Well, welcome to today's lecture. If you don't know me already, my name is HIPAA Kolodrobitz. I'm a family nurse practitioner, board certified by the ANCC, and today's lecture is going to be on the professional role. So we'll break that down. What does that mean? What are the different aspects that you're going to need to know for both clinical practice and if you're sitting for the ANCC boards, you're going to see some questions pop up about this as well. So it's important for you to review these topics, get familiar with them, and practice some practice questions, which we'll do in today's lecture as well, so that you're prepared for those questions as they come up on the boards. So before we get started, if you haven't sat for one of my lectures before, you'll know, or I like to tell people is I like to keep it engaging. So even though this is kind of a little bit of a dry topic, I'll still try to keep it engaging by asking you some clinical questions as we go along. So keep that chat box open. We have our lovely Miss Morgan helping us on our chat box today. So any questions you have as we're going through the lectures, feel free to ask. We'll answer everything. And then at the end, we'll also have a Q&A where we'll answer some questions, both about this lecture and just anything related to Archer that you could think of. I'll put this slide up again at the end so you guys can snag that QR code for all our free webinars if you haven't already. We'll talk a little bit about our 3-day live reviews at the end. But I just want to go ahead and get started because we have some good things to cover today. We'll go over that slide again at the end. So like I said, in today's lecture, we're going to talk about the professional nurse practitioner role, what that encompasses. We're also going to talk a little bit about nurse research and the legalities and some terminology that we need to be familiar with for both the boards and clinical practice. So the way I like to start this presentation is, okay, you've passed your boards, now you're ready to see patients. What's next? What do you need to know when you're entering your first clinical experience? So thanks to the HITECH Act in 2009, most of the clinical practices now are on electronic medical records, or EMR. It's also referred to as electronic health records, EHR. Those are interchangeable. So you as a nurse practitioner, in addition to having to know all the ways to treat all the different health conditions, also need to know how to navigate these EMR or EHRs, right? So that's going to be part of your professional role as a nurse practitioner. There are a lot of tools on these EHRs that can help you, but it is something that you have to get comfortable with. It comes with time and experience. And you want to make sure that any clinical practice that you decide to work in, you understand the EMR and the EHR, and they're providing adequate training, providing you with adequate time as well to get trained up on their particular EMR system. So let's back up a little bit. Why do we have these electronic health records? What's going on? So back in 2009, with the growth of the internet, Congress recognized that there needs to be a way to enforce not only patient privacy, but also protect the privacy of these medical records and also protect us as clinicians. So they passed the HIPAA Act in 1996. HIPAA stands for the Health Insurance Portability Act and Accountability Act, and it has 5 titles. So most people know HIPAA based on its protection, and that is one of the goals, but actually it does have protection for privacy for medical records, but it also helps protect any fraudulent activity for providers too. So there are a lot of different sections that fall under HIPAA. There are 5 titles, and we'll break those down in just a minute. But it also helps prevent discrimination for our patients and also protects any kind of fraud as well. So it's really important, especially as we continue to see growth in the internet and the electronic medical records just being available to other people who could get access to them, who we don't want having access to. So let's break these 5 titles down really quickly. So Title I in HIPAA, this is a title that protects health insurance coverage for individuals who lose their jobs or have any pre-existing conditions. So if you've ever been in a job and you've had to leave that job, they legally have to offer you COBRA. So that's thankfully, due to the HIPAA Act in '96. Prior to that, that wasn't the case. Title II requires every provider to obtain an NPI number to prevent that healthcare fraud and help also promote privacy when we're transferring information from provider to provider. So when you enter clinical practice, you will register and get an NPI number, and that's going to live with you throughout your NP career. So that doesn't change as you change practices. That is going to be your unique provider identification number. Title III addresses any pre-tax medical spending accounts like HSA accounts that you get through your employer and patients can use for their medical expenses. And then Title IV talks about group health plan guidelines, and Title V talks about company-owned life insurance policy guidelines and guidelines for treating patients who are uninsured and not U.S. citizens. So how might this pop up on the boards? Let's talk a little about that. So here's our first practice question, just to break it up and make sure you guys are all with me and awake and present. So go ahead and open that chat box and let's go through this question together. Remember, what I always say in my lectures is I don't care if you get it right. I just care that you participate. I much prefer you participate and get it wrong today and then get it right on your boards exam. So don't feel shy. Just throw in an answer and we'll talk through the rationale, okay? So practice question number 1. All of the following are possible examples of HIPAA except, so is it A, Mr. Smith lost his job last month and he's eligible for COBRA insurance plan? B, a front office staff member using a screen protector on their computer. C, Mrs. Floyd has her company put pre-tax earnings into her HSA flexible spending account. Or is it D, Mr. Kelvin, a 58-year-old male with end-stage renal disease, is applying for Medicare? So which are all the following are examples except which one? So Ruby, thank you for participating. I want to see some more participation. Thank you, Anisha. You guys are doing great. So which one is not an example of HIPAA or doesn't fall under HIPAA, those 5 titles that we just talked about? Okay. So you guys did great. D is the right answer. So why is that? So all of them fall under those titles of HIPAA, except D actually falls under its own title. So that's the End-Stage Renal Disease Amendment of 1978. So remember that first one is COBRA, that's under Title I. And then we have front desk staff member using that screen protector, that's privacy, that falls under HIPAA. And then C, Mrs. Floyd puts her money in an HSA account, that also falls under HIPAA. So awesome job. The more you practice these questions, the more it'll make sense and the more you'll get it right on the day of the exam. So now let's talk a little about billing. Billing is a very large topic, and we're going to just briefly talk about it a little bit. We'll probably have a separate lecture on billing if there's some demand for it. If you guys are interested, we could talk about that. But basically, billing is something that's going to be part of your role when you enter clinical practice, and it's something I want you to get comfortable with because it'll also help you determine whether you're getting paid adequately when you enter a new relationship or even an existing relationship with your employer. So billing is we render medical services and we bill insurance companies and they pay us for the services that we've rendered. And we use ICD codes, and ICD stands for International Statistical Classification of Diseases and Related Health Problems codes. And these are just medical classification lists that was developed by WHO, the World Health Organization, used for insurance claims and processing. So the insurer knows you saw this patient there's an ICD code for hypertension, diabetes, otitis media. So you have to code what you saw that patient for. What was your assessment and diagnosis, and what are they paying you? What are they reimbursing you for? Our current version are ICD-10 codes. In the future, there'll be ICD-11 once they upgrade them and so forth. It'll go that way. One thing I wanted to highlight about codes is incident to billing. So this is becoming really popular because a lot of practices are trying to bill under the physician to get 100% reimbursement for those visits as opposed to the 85% reimbursement that we get as nurse practitioners. Be familiar with what that means and make sure that you understand when you're documenting what an incident to billing is. So there are different criteria that you have to make sure it's that chart note is met. So the physician has to be in the building and it can't be a new problem. So this is best served for clinical scenarios where the physician has seen the patient is established with a physician within your practice, and they have created the plan of care, and you're seeing that patient for ongoing follow-up that falls under that plan of care. So you're then following up on their hypertension medication that was started by the primary care clinician, and you're caring for them to make sure they're doing well on the medication. They don't need to increase or decrease the dose. It's an already pre-existing plan of care. If it's a new condition in that visit, then that would not be an incident to billing. So we wanted to highlight that because that's becoming more and more popular as practices are struggling financially and wanting to bill the incident to and getting that 100% reimbursement. Billing, like I said, is a very complicated and big discussion point. One thing that you need to get comfortable with and make sure your practice allows you the resources to get comfortable with it and you understand it, and they give you the tools that you need to understand it so that you're billing accurately, because most providers either underbill or overbill, and you want to make sure you're billing accurately just for yourself as well as to help keep our global healthcare costs down. So now let's transition to talking about the Patient Protection and Affordable Care Act of 2010. This is also known as Obamacare, so you probably have heard of this. What are the goals of Obamacare? The three main goals. The first goal of Obamacare is to make affordable insurance available to all patients. The second goal is to expand that Medicare program and allow coverage for adults that fall under that poverty line. And the third goal is to really help drive down those costs of overall healthcare so that patients aren't paying so much out of pocket and we're not paying so much globally for our healthcare. So there are different types of health insurance plans. You've probably heard of HMO and PPO. So an HMO stands for Health Maintenance Organization. A PPO stands for Preferred Provider Organization. And so the difference between the two is HMO is a lot more limited, smaller network of providers, but the promise is a lower out-of-pocket cost to that patient. And a PPO, it's a larger network of providers, there's not as much limitation, but higher out-of-pocket cost to your patient. And with both the HMO and PPO, you get options for vision, dental, medical prescriptions, hearing insurance benefits for those geriatric patients. So knowing the difference between HMOs and PPOs is also beneficial to you because you need to be able to see what is happening with your patient. Are they on an HMO plan? Are they on a PPO plan when you're ordering different things? And then the main difference between Medicaid and Medicare is also important to know. So these are both low-cost healthcare plans to help focusing on certain patient populations. So Medicare is more of a state-specific program, and it's state-funded, and it's intended to serve patients under the poverty line, low income. It's generally free, and it covers basic healthcare. Medicare is a federally funded program, and it's generally intended for patients ages 65 and older, and if they're under the age of 65 and qualify with certain disabilities. It covers about 80% of care. It's usually medical and hospital care, so parts A and B are covered, and then patients can always purchase supplemental plans at parts C and D. And again, it's important because patients are going to be asking you, is this covered? Is this not covered? So knowing the different types of plans is going to be helpful to you in the clinical setting. Now let's talk about parts of a valid prescription. You'll definitely see some questions about this coming up on your boards, and you want to get comfortable with this as well. Your EMR, your electronic medical record, will probably prompt you to put in these pieces before you can electronically send the prescription, but there are just also good things to note that we'll talk about best practices when you're putting in these pieces for your prescription to go over to the pharmacy. The superscription, that's what comes before the body of the prescription. So that's the patient's name, date of birth, address, the current date that you're sending in the prescription. The inscription itself is the name of the medication, the dosage amount, and the subscription is the instruction for the pharmacist that you want them to put on the vial so that the patient knows how to take that medication. And that's referred to as the signa or sig. Those are the instructions for the patient. So remember, best practices for pediatric patients, you always want to put the weight on there. And then when you are sending a prescription, it's also going to ask you for refill or not. So you'll have to note that. And then you're going to authorize and sign your name to it. You have to put in the address of your practice site and also your NPI number. And then if you're sending in a controlled medication, you'll have to put in your DEA number as well. There's a word of caution in there. Don't just sign blank prescriptions and keep it in your drawer. Most practices don't even give you paper prescription pads anymore, but you never want to just have prescription pads with your signature laying around. You want to make sure that for best practices, you are signing each prescription as you go along and see those patients. So here we have a quick practice question just to make sure you guys are with me. We'll go over this together. Let me pull up the chat myself so we can see the participation. So while working in an urgent care, the nurse practitioner is providing a 9-year-old patient with a prescription of amoxicillin for 250 milligrams for bilateral otitis media. The nurse practitioner wants to write on the prescription for the patient to take 1 tablet twice per day. On which part of the prescription should this information go? Is it A, the superscription, B, the inscription, C, the subscription, or D, the signa? So go ahead and put your answer. Again, just care that you participate. Thank you for the participation, Ruby and Onisha. You guys are doing great. Thank you, Jasmine. I want to see a couple more people participating. Don't be shy. All right. So the answer is D. So the signa. So the signa is the part of the prescription the pharmacist writes for the instructions on how to take the medication for the patient. And then, of course, I already told you this part, remember, because the pediatric patient, best practice, you always want to put the weight on there. The pharmacist also double checks the dose for you. It's a nice checks and balances system to make sure that you're sending in the right prescription for that patient. So that's going to be helpful. Our pharmacists are really a great resource. If you ever have any questions, pick up the phone and say, hey, this is what's going on. This is what I want to prescribe. This patient has these kinds of allergies. This is what I'm thinking. I love our pharmacists. They're a wealth of knowledge, so don't be afraid to utilize them. So putting that patient weight on there is another way to utilize their resource and make sure that you're sending in the right dosage for your patient. Okay, so now let's shift to talking about research and legalities. So you're going to see some terminology pop up, both about clinical research and some legalities that we're going to go over today. Again, I'm going to try to keep this as light as possible, and you guys participate and ask your questions as much as possible, but it is a little bit dry information. But why do we need to know about research as we're entering into clinical practice? Weren't we done with all that with the capstone? You never have to think about it again. The reason why it's so important is as you're practicing in clinical practice, things are going to change. Guidelines change. There's going to be more research that comes out, and you have to really be able to figure out, is this research statistically significant? Is this something that I need to now incorporate into my clinical practice as the science changes? So making sure you know how to interpret the research that's coming out is going to be really helpful for you to stay evidence-based, right? So let's go over some of the common terminology that you probably reviewed in your statistics course, and it's going to pop up again on the boards. So the variable. So variable is the measurable data fact. So that's going to be more like age, eye color, weight, gender. So you're going to see the variable in the research that you're reading or trying to interpret. Statistical significance, that's going to be your p-value. So again, it's going to determine whether what you're seeing, the relationship that you're seeing, is fact or coincidence. And the smaller the p-value, the stronger the observed relationship, that it's more due to fact than coincidence. And then some general terminology: mean, indicates average, median is that middle number, and then mode is the number that occurs most often, and range is the difference between the lowest and the highest numbers listed. I want to talk a little bit about systematic reviews. It's the best, it's the highest level of evidence and quality research that we currently have. Again, why are systematic review studies so great? So they take multiple studies and combine them into one single document, and it's really transparent. So typically, it has a table that shows you what search databases they used and how many research trials were looked at and what the inclusion and exclusion criteria was, which one they kept and why they kept it. And it helps you see the best evidence that's out there. And then the biggest point for systematic review is the discussion point, because then you have experts in the field weighing in on the research. So it's a really great place to start when you're looking at a clinical scenario where you think, okay, how am I going to treat, what is the best way now to treat this otitis media? Then you're going to look at the clinical research through a systematic review, and it's going to really break it down. Or what is the best way to prevent osteoporosis in my postmenopausal patients? So it's a really nice way to start looking at the research that's continually being done on the back end while you're busy on the clinical end. So here's some more common terminology. Don't worry, I'll give you all the definitions at the end. I'll tell you when you can grab a screenshot of it or take a picture of it with your phone. But for now, I'm going to try to make it a little more interactive by putting some questions in here. But some common terminology that you may see pop up on the ANCC boards, that they're going to give you clinical scenarios and ask you what that is an example of. So we'll go over that. But non-maleficence, beneficence, autonomy, confidentiality, justice, veracity, fidelity, utilitarianism. These are just some common terminology that I want you to be familiar with as you're studying for your boards exam. So let's open up our chat box and go through our first practice question. All right. So while seeing patients in a busy primary care office, the nurse practitioner always takes the time to run medication through the interaction checker before refilling any prescription. So generally, if you're on a fancy EMR like Epic, it does it for you when you're sending in the prescription, and then you can either keep the things that it's flagging or dismiss it and sign off on it. But if you're on a different EMR, it's not going to do it for you. So best practice, always use that interaction checker just to make sure that you are prescribing safely. The nurse practitioner notes that there is an interaction between two medications and they decide to change the regimen. So don't be afraid to call patients and say, hey, I noticed this, I want to change the regimen, and talk to them about your new plan. They really appreciate it because it's always safety first. The nurse practitioner explains this to the patient and they are agreeable to take a safer option. This is an example of, is it A, fidelity, B, justice, C, non-maleficence, or D, accountability? What do you guys think? What is this an example of? Don't be shy. Oh, thank you, Anisha. There you go, Jasmine. Look at that participation. You guys are doing great. So C is the correct answer. This is an example of non-maleficence, which is the commitment to do no harm. So remember, safety always first. Slow it down. It's going to get really busy in clinic. Use that interaction checker and call your patients and change the plan and explain to them why. This is really important. Again, our pharmacy partners try to do this as well, but if the patient's using a new pharmacy and the pharmacist doesn't have all the patient's medications on file, they can't help us as much. We really should be doing this every time you're prescribing a new medication or refilling a medication. So making sure safety first is always going to be key in your clinical practice. So awesome job, you guys. Practice question number 2. While traveling to work one morning, a healthcare provider witnesses a traffic accident and stops to render aid. So don't be afraid to do that. I know a lot of providers aren't sure if they're allowed to or not. Don't be afraid to do that. The provider, they stay and help to stabilize the victim until emergency medical personnel arrive at the scene. This is an example of A, is it veracity, B, justice, C, fidelity, or D, beneficence. So what do you guys think? All right, Jasmine and Ruby, love the participation. Onisha coming in strong. I love it. All right, you guys. D is the correct answer. So this is an example of beneficence. So it's the act of promoting welfare and safety to all. So that's great. All right, our last practice question for this part is terminology. The nurse practitioner is working in an urgent care and is assessing an ingrown toenail. Noting that the patient needs a toenail avulsion, the nurse practitioner explains the procedure to the patient beforehand and obtains consent before starting the toenail removal process. This is an example of, is it A, autonomy, B, utilitarianism, C, fidelity, D, non-maleficence? What do you guys think? All right, and I always laugh at this question because I think like, I couldn't even think of a scenario where you wouldn't be explaining the procedure to the patient before removing their toenail. But I I hope that's not happening anywhere. But anyways, I digress. Thank you, Ruby. Thank you, Jasmine. You guys are doing great. So the correct answer is A. So autonomy. This is an example of the patient exercising their autonomy to make their own clinical decision making. You've explained it to them and they're able to participate in their treatment plan. So awesome job. So here's the common terminology that's listed out for you. I'm not going to read through every single one because if you're anything like me, once someone starts reading these things to me, my eyes glaze over and I don't process a single thing. So just take a screenshot, take a picture, read through it. But my biggest suggestion is to you is to practice those practice questions because they're going to give you that clinical scenario and you're going to have to decipher which definition or what it's an example of, like we just did with those 3 practice questions. So practice, read the definition, but practice is really going to go a long way for you when you're looking at these definitions. So I'm going to give you guys a few more minutes to take a screenshot, and then we'll move on to our next slide. Okay, I think everyone's taking the pictures that they want. Okay, so I'm going to wrap up this legal section by talking about malpractice lawsuits. Of course, nobody wants to be sued. We all have malpractice insurance. You want to make sure you have good malpractice insurance when you're entering clinical practice from your employer. There are a lot of situations out there where the employer might not provide malpractice insurance. So you want to make sure you're okay with that. And when you're buying your own malpractice insurance, you have adequate coverage. But lawsuits do happen. How do we try to prevent lawsuits? Always practice within your scope of practice that's outlined by your particular state, by the state's Nurse Practice Act. So in the clinical scenario, it's going to get very busy. Always slow it down and think to yourself, is this something I feel comfortable managing? Is this something I feel comfortable treating, diagnosing and treating? If you don't think, is this something that I need to be pulling in a physician colleague or just another NP colleague to talk about this? Is this something that needs a specialist to look at? So making sure you're not practicing beyond your scope of practice, even if you're getting pressured by the patient or by your employer, which it will happen, you want to make sure you slow it down and you stay true to your scope of practice. And don't be afraid to pick up the phone. So if you feel like, you know what, a specialist really needs to be taking a look at this clinical scenario, pick up the phone, talk to that specialist, get that patient in. I remember this was like 8 years ago when I first entered clinical practice. I had a patient come to my office, non-English speaking, had just been seen in the ER, couldn't urinate, and they put in a catheter and discharged him. And he had no idea what to do, came into my office and couldn't tell me what happened in the ER, couldn't tell me what's going on. So aside from getting a translator to help us put the story together, I picked up the phone, called urology, and got him in same day to make sure that we were doing the right thing for him and following a treatment plan that I couldn't give him, but I was definitely helping connect that care, right? So you don't have to be expected to treat everything, but making sure you stay within your scope of practice and helping your patients getting the care that you need is our main role in primary care and can help also prevent some lawsuits. Also making sure you maintain your license and certification and stay current on clinical knowledge. Doing your CMEs is really important, keeping track of your CME. So I usually keep track of it on my Google spreadsheets of my different licensures, when they expire, how much CME I have. So keeping nice documentation both for yourself and if a lawsuit comes up, it's going to be really important. And then prompt documentation is going to be really important. So again, it gets really busy in clinical practice. What I do when it gets that way is you always want to make sure you fill out your HPI right then and there as the patient's talking about it. It doesn't have to be pretty, but getting the information down in your HPI and then go down to your assessment and plan and free texting what you saw on your physical, because it takes a lot of time to click, especially certain EMRs. You have to click through every single thing for your physical exam, but making little notes for yourself in your assessment and plan and just jotting it down. If this is my assessment, this is my plan, and then you can always go back and clean it up later, but getting it in there in that chart before you move on to the next patient takes 2 minutes, and it'll save you a lot of time on the back end, because as you're seeing patient after patient after patient, you're not going to remember that patient that you saw 10 patients ago. So making sure you get it down promptly is going to be really important. And then trying to complete your charts. I like to do them same day, even if you're exhausted. Getting home, getting through those charts is going to be really important, because you are not going to remember that patient as you do see more and more patients. And if a lawsuit comes up, your chart note is the only thing you have to go by when you're defending yourself. So you want to make sure you document well, and you put the information in there of what actually happened in that visit. So hopefully it'll jog your memory if it ever comes up again. And then maintaining files that support your character. So if you have performance reviews, anything like that, keeping those on files, printing them, saving them is going to be helpful to you as well. All right, so that concludes our legality and research section. Now let's talk about the cultural beliefs and special considerations for different cultural groups. So this will help us care for our patients as a nurse practitioner in a culturally sensitive way. Before I start the section, I want to just point out that, these are very big generalities. Always treat your patients on an individual level, because patients don't always fall into these boxes, but it's good to know about these different cultures on a general high level, as well as you're treating your patient population. So let's start by talking about the African American population. This patient population is generally very family-centered with strong religious and spiritual unity. So in this population, we are seeing that they're becoming more health conscious, and they're seeking more regular health treatments and screenings, which is great. In the past, there was a lot of mistreatment with this patient population in healthcare, so they are skeptical and not trusting of the healthcare system within their right. So making sure that as you're talking to this patient population, you take that into account, and you're very sensitive and open to hearing the patient's concerns about why they don't want to take certain medications, and working with them on an individual level is going to be really important. So they may be reluctant to disclose some personal information. Give it time, build that relationship. All right. And then in recent years, there have been efforts to conduct health screenings in churches where this patient population may feel more comfortable and may have more trust in the providers that are there. Some specific risks to this patient population, there are more risk for high blood pressure and stroke because of the health screening events that and early intervention that they're not doing. So moving on to Latino and Hispanic population, this group is generally also very family-centered and religious, with deep respect for the elders and authority. Older members of this population will appreciate being addressed by their last name and engage in small talk before starting the exam. And then barriers to healthcare for this patient population are usually due to lack of insurance or poverty, or language barriers. This group is often open to seeking treatment, but may not have access. So may have underutilized the screening and preventative care due to lack of insurance or lack of finances. So risk to the Latino and Hispanic population due to the decrease in preventative care. There seemed to be a higher rate of diabetes, GI cancers, and stroke among this population. Now we're going to talk about the American Indian population. So collectively, this population believes in the Creator. They honor the generosity toward fellow man and the greater good of the community. That's of the utmost importance to them. They do have sacred healing traditions and rituals and ceremonies to help promote that interconnectedness between spirituality and the physical ailments. Some members of this group may carry mementos or herbs of medicine pouches or bags to help treat the spiritual conditions like pain, alcoholism, mental health. And some risks specific to this patient population. So common health conditions within this population are obesity and alcoholism are the biggest ones, which can lead to type 2 diabetes, advanced renal disease, heart disease. And then in our Asian population, so in this patient population, they have extreme respect for their elderly. That's key to the Asian culture. And oftentimes these families are live together, multi-generational homes. So they might have mom, dad, grandma, grandpa, and the kids all within the same home. The elderly also appreciate being called by their last name. A handshake might go a long way, and they like to be seated before engaging in conversation. And they find that interruption is really rude, so you want to really practice active listening in this patient population. And then one of the most popular religions in this patient population is Buddhism. And this group is also most likely not to have a primary care doctor. And we've been seeing that more in the Vietnamese patient population with their preventive visits. So some risks to the Asian patient population: cancers, most notably cervical cancer because of that lack of screening. We also see diabetes, heart disease, and respiratory illness like COPD more commonly in this patient population. And so before we move on, I want to do a quick pause and talk about traditional Chinese medicine. So what are some examples of traditional Chinese medicine that you guys are aware of? Go ahead and put that in the chat box. So these are examples of complementary or alternative medicine that you may have seen or read about. And we have some pictures of it here just to give you some clues. All right. Don't be shy, it's okay. So acupuncture, cupping, which is the picture here on the right, massage, Tai Chi, these are some examples of traditional Chinese medicine. And so in traditional Chinese medicine, QI is pronounced as qi, and they really want to have a balance of the qi. And if there's illness or disease, they see that as an imbalance in the qi. So that's something you might see in this patient population, that they do utilize the traditional Chinese medicine along with the Western medicine and those screening guidelines that we talked about in last week's lecture. So now in our Indian American patient population, Indian Americans typically value family, education, and the elderly, and parents play a big role in their children's lives. So if you're seeing a pediatric patient who is within this patient population, keep this in mind. But parents typically provide a lot of direction for their children, including advice and arrangement on careers, marriages, health, certainly. And those who follow one of the main religions in India, Hinduism, may also prefer a vegetarian diet. And also this patient population may believe that Western medicine overtreats health conditions. Some risk factors that are increased in the Indian American patient population: chronic diseases, such as diabetes, hypertension, high cholesterol, and mental health concerns. So Islam is one of the fastest growing religions in the world, and it originated in the Middle East. And Muslim people who practice Islam follow the Quran. Those who practice Islam often with family, and they look to the men to lead, and the women play more of a domestic role. And some other preferences include being treated with a medical provider of the same gender. They might be more comfortable. So if you have that option in your clinical practice, offering that to your patient would be helpful. Patient care considerations for the Muslim patient population. So this population typically avoids alcohol and prefers to stay away from pork-derived medication like insulin, epinephrine, gelatin, heparin. So they could be willing to utilize those medicines if no alternative is available, but thinking about alternatives when you're prescribing for this patient population is going to be helpful. In the Ashkenazi Jewish population, these people it's referred to a group that originated in Eastern Europe, and about 80-90% of these, those who identify as Jewish will identify as Ashkenazi, I'm sorry, I'm mispronouncing it, regardless of the country of origin. So those who practice the religion of the Jewish people, Judaism, seek to promote social justice, life, fairness in general, and Judaism can be broken down to three main sects: Orthodox, Conservative, and Reformed. And these are different ways that we refer to the interpretation of the Torah or the Jewish law. Some increased risk factors in Ashkenazi Jews: genetic diseases like cystic fibrosis, Tay-Sachs, Gaucher disease are more commonly seen in this patient population. And so we talked about a lot of different groups that we outlined today, but remember, within these groups, it can include vulnerable patient populations, and that refers to people who may identify as LGBTQ, if they're pregnant, impoverished, of minority within their own culture. So making sure at the end of the day, we treat people with respect and as individuals, and build that relationship to really talk to your patients about their own individual beliefs, and respecting their beliefs as you're caring for your patients is going to go a really long way. And then this little resource here that I think Brittany put into our lecture and found is a really helpful resource by Stanford Medicine that talks about delivering culturally sensitive care to our geriatric patient population. So if you have time to read that, I think that's going to be really helpful. Stanford Medicine in general has a lot of great resources for providers. So if you haven't already downloaded their podcast, listen to their podcasts occasionally when you need something in your downtime. But Stanford Medicine also has a lot of great resources for providers that you can utilize in clinical practice or as you're preparing to enter clinical practice. So we're going to wrap up today's lecture with 2 practice questions, and then I'm going to open the floor up to any questions that you have on what we talked about today, or just anything related to the boards coming up or our 3-day live review that we'll talk about in just a minute. But we're going to wrap up with these 2 questions. So question number 1, an 81-year-old client comes in to establish primary care and is accompanied by her husband and daughter. Her family is concerned about her weight loss, and her daughter states she hasn't eaten anything after arriving to the United States. After speaking with the client using an interpreter, the nurse practitioner finds out that she moved here 4 months ago from the Middle East. Islam is her preferred religion, and most of the food offerings here are unacceptable. The nurse practitioner decides to consult the dietitian to help the family navigate the transition. Which dietary knowledge would be the best fit for this patient? So go ahead and enter into the chat what you think would be would be the best fit. Is it A, Mediterranean, B, kosher, C, vegetarian, or D, halal? Okay, good. I see Ruby, Jasmine, Onisha. Good. I love that you tried, Onisha. That's great. Thank you. You guys are doing great with the participation. So yes, you all got it correct. D is the right answer. So halal would be the dietary preference for someone who identifies as Muslim. And so you want to try your best to find a dietitian with working knowledge of halal prepared foods to help this patient make sure she's getting the caloric intake that she needs. Excellent. Awesome, guys. So our last practice question: a 57-year-old Asian female comes to the clinic for a sore throat and headache. She states she also has a rash on her chest and neck and wants that looked at. Upon further examination, the nurse practitioner observes exudates on the tonsils, red sandpaper rash on her chest, stomach, and neck, and some perfectly round purple marks on her back as pictured below here. What is the next appropriate step? A, is this abuse? Should we screen for abuse? B, ask if the dark spots itch. So ask more clinical questions to help you determine where these dark spots are coming from. C, perform a rapid strep test. Or D, refer to a dermatology because it's not within your scope of practice. So what do you guys think? Okay, Jasmine, Ruby, awesome participation. Come on, you guys, what do you think? So are we worried about this patient, and why should we be worried? So C is the correct answer. You should perform a rapid strep test because of the sandpaper rash and the exudate on her tonsils. This patient most likely has strep throat. So those dark spots are due to cupping. So we had a picture of cupping earlier, and this is a form of traditional Chinese medicine. So it's not abuse. It's not something that a dermatologist needs to look at, but it is something that is part of the culture and no further action needs to be taken. So awesome job, you guys. So now I'm going to leave the floor open with just a few minutes left in our lecture for any questions you guys have. Before we wrap up, I want to make sure you guys know about all our great resources. So you came today, so I know that you know of our free webinars, which is great. We have free webinars every week on various different topics to help you prepare for your boards and your clinical practice. If you haven't already, scan this QR code. It helps you register for all our webinars coming up so that if you can attend, that's great. We both live stream them and have you participate in Zoom. So whatever way you prefer, you can participate. And I appreciate everyone's participation today because it'll help you prepare for your boards. We also have 3-day live reviews, and our next one coming up is actually starting this Friday, Saturday, Sunday, and it's not too late to register if you are looking for a review before you sit for your boards exams. It's really great because it's an in-depth review. It covers all the topics, and you have access to all the NPs live those 3 days, so you can ask your questions. We go through a lot of exam questions as well, but we hit the highlights and make sure that you are prepared for your boards. If you can't attend a 3-day live in person, what I really like about them is if you register, you actually get access to the videos for 30 days. So even if you can't make this Friday, Saturday work, if you register, you'll get the videos and you can just watch them on your own time and prepare that way when you do have time to watch the videos. And it's just $50 for a huge 3-day live review. So I'd love to see you this Friday, Saturday, Sunday. And if I can't see you, I'd love to offer those videos to you as a way to prepare for your boards exams. And then we have a lovely Q bank. You can try it free for 30 days. If you like it, you can purchase it for just $29, which is amazing. And it has over 1,500 questions. What I will say is the Q bank is hugely important because the more practice questions you go through, the more you'll learn about what you're studying, and you'll learn what areas you need to go back and learn more about. And you learn a lot through the rationale. So it's a really great way to assess how you're doing and how prepared you are for your boards. And it also gives you an estimate of how ready you are for sitting for your boards exam. So it's really helpful, and just practicing those exam questions are going to be really helpful. We actually just had one of our RNs go through all the Q bank questions. She went through all 1,500 when preparing for her boards, and she just passed first time for her ANCC boards exams. And all she did was the Q bank questions. So really, really great stuff in there. You learn a lot from the rationale. So I really highly, highly recommend the Q bank. And then, of course, you can always connect with us on our social media. We post a lot of great things and a lot of free giveaways on social media. And our email is always up there for you guys too, because we're here for you for anything you need, from mentorship, tutoring, to any questions you have, any test anxiety, or just don't know where to start. We're here. Feel free to send us an email, and we will support you not only for your boards, but also entry into clinical practice. And with that said, I'm going to open up the floor to everyone who attended today to ask any questions you have about what we talked about the boards, about Archer, 3-day Q bank, anything we just talked about, and leaving it wide open for you guys to ask your questions. You're very welcome, Anisha. Thank you for coming today. And if you guys have to hop off, if you don't have any questions, I really appreciate that you attended today and took the time out of your lunch break or your morning, wherever you are, to listen to this lecture. It is an important part of preparing for your boards and your clinical practice. So you did a great thing for yourself today. And I always love seeing some familiar names and faces. So I appreciate that. And I know this is a big topic area, so any questions you have about clinical practice in general, any of the topics we went over today, feel free to ask. I know it can feel a little overwhelming at first, but you definitely have some great resources in both Morgan and I. We've been practicing for a long time. All our NPs have been practicing for a long time. So we've been there, we've gone through it, and we're here to help. So any questions you have, you can also DM us privately. Don't feel shy. This is your time to ask. All right. If we don't have any other questions, again, thank you so much, you guys, for participating today. I love, love, love the participation. It really is so beneficial to you. You're going to be so much more prepared for your boards by participating and getting it wrong now. You will get it right on the exam, I promise. The more you practice, the better you're going to be off. So I really appreciate everyone coming today, and we'll see you on the next webinar.